Today I will be presenting two case studies, one for Bob and the other for Bill. By the way, Bob and Bill are not their real names. First, I will briefly discuss Bob's periodontal condition since he was my very first patient for the project. I was able to obtain various intraoral images, got his dental impressions done, and made his dental casts. However, I wasn't able to complete his dental treatment due to certain circumstances. Despite the difficulties I had encountered, there were great learning experiences for me. This is patient Bob's study model. These are the first dental casts I made for a patient. This is the introduction and patient selection. In March of 2018, I volunteered to provide dental services at Compassion Clinic at East County Church. I met patient Bob's father, who was one of my patients at the event. I told him I needed a perio patient for my project, upcoming project. So he said that his son hadn't had his teeth cleaned for 10 years. So I scheduled his son for an oral evaluation. And I determined that he has an active periodontal disease. Unfortunately, he couldn't continue his dental treatment due to his circumstances. He was hired as a landscaper and he just couldn't pass up the opportunity. Because of what happened, I needed another perio patient. I then met patient Bill. He was given to me by a classmate. Bill's treatment was an accelerated version for my project because I was pressed for time. My board exam was fast approaching at that time. Obtaining his intraoral images and dental casts were skipped during his initial visit since I already had done it with patient Bob. This is patient Bob's brief information. This is just a quick overview of patient Bob's biographic data and his medical and dental history. Based from the periodontal or gingival assessment, Bob would have been a perfect patient for my project, for the perio project. This is patient Bob's periodontal and gingival conditions. His periodontal disease was moderate to severe. His periodontitis was advancing to a concerning level. Most of his furcation defects were class 2. His gingivitis was severe. His gums were enlarged, inflamed, and erythematous, and some were cyanotic in color. Consistency and pocket integrity were generalized soft and placid. Unfortunately, he had to withdraw from treatment. This is patient Bill. His treatment was, like I said, was an accelerated version of my perio project. This was recommended by my clinic instructor. Since I already had done the dental casts with my first perio patient for this project, the required study model was waived due to time constraints. This is patient Bill's biographic data. He reports generalized bleeding and sensitivities, food catching between teeth, bleeding when flossing, floss breaks, snugs or shreds, and sometimes gets stuck between teeth, and this may be due to calculus deposits. He also mentioned generalized gum bleeding. And he's a resident of Portland, Oregon, 41 years old, white, unemployed, single, and he hadn't had his teeth cleaned for 16 years. Rationale for selection. Patient has presence of suspected caries lesions and he really needs help. He has active periodontal disease with generalized slight to moderate horizontal and localized moderate vertical bone loss, has moderate supra and heavy subgingival calculus. He gave consent to participate in the periodontal project and was happy to have been chosen to participate and was ready to start his new oral hygiene regimen. For subjective and objective data, Bill had no chief complaint. All he wanted was to have his teeth cleaned. His medical alerts are the following. Allergic to penicillin, is diabetic and has constant pain in his left hip and shoulder. And for his health history, he has type 2 diabetes, hypothyroidism, arthritis, and bipolar disorder. He takes a few medications. I think there are 5 medications. For dental history, he has clinical history of restorative work, which include amalgam fillings, composite fillings, and sealants. And for personal notes, he suffers moderate to severe hip pain and wants to be warned before lowering and raising his dental chair during treatment. And Bill set goals of losing weight and having regular dental cleaning to improve his oral and general health. For subjective and objective data, Bill needs to be referred to a regular physician due to high blood pressure readings. However, his pulse rate and his respiration are normal. He also tries to avoid starchy food, which is great for his diabetic condition. He has bipolar disorder, hypothyroidism, like I mentioned earlier. However, he takes his medication daily to stabilize or improve his medical conditions. That's why he's classified as an ASA2 patient. For intra or extraoral findings, there is nothing to report that is significant for AOIO, except the pain that he has on his TMJ. For oral hygiene status, patient has dexterity problems plus an issue with shoulder pain. This interferes with brushing his maxillary teeth. I believe the left side. His hygiene consists of frequent use of regular toothbrush, using whatever toothpaste he finds. No mouthwash, flosses occasionally, and so forth. And due to these poor habits and having no dental cleaning for 16 years, he has chronic generalized severe gingivitis and slight to moderate periodontitis with a high caries risk. Initially, his interdental bleeding was 75%. Patient regularly consumes a high amount of sugar, drinking soda, sweetened iced tea most days. He prefers white bread to whole wheat, etc. But I did recommend to him to change from, instead of using white bread or eating white bread, I told him to eat whole wheat bread because it's more nutritious and healthier than white bread. So for periodontal status, for his gingival description, he has generalized moderate erythematous in color for marginal and papillary. generalized enlarged patella, etc. Summary of probe depths and furcation involvement. Probe depths ranging from 1 to 5 millimeter in both anterior and posterior. 4 to 5 millimeter probe depths, mostly on posterior, and he also has class 2 furcation, class 1 and class 2 furcation defects in some of his teeth. For gingival recession, generalized slight recession of 1 millimeter and localized moderate ranging from 2 to 3 millimeters. For total attachment loss, 1 to 3 millimeter gingival recessions totaling 1 to 7 millimeters of attachment loss, and so forth. I'm not going to mention everything that's in here, but he does have mucogingival defects, and his microbial assessment is he's considered as high risk. This is his periodontal assessment data. Current condition of teeth. Patient has 25 teeth. One is unerupted and impacted. Number 10 is congenitally missing. Sorry, I have trouble pronouncing that word. He also has class 1 mobility issues. His types of existing restorations are amalgam, composite, and sealant. He was diagnosed with 3 incipient caries and other carious lesions that involved several teeth. He's considered a high-risk patient for caries due to his current condition and his regular consumption of cariogenic beverages. For occlusal analysis, another periodontal condition, the angles classification for left posterior is open bite, otherwise class 1. And they're all in here. And for radiographic findings, based on the radiographic findings, Bill is an AP2, localized 3 patient. His severity and distribution is slight to moderate horizontal and localized moderate vertical. He does have widening periodontal ligament spaces. He also has defective restorations, but I wasn't able to obtain this information due to my clinic dismissal. For radiographic calculus, there are several of them, and so forth. He does have periapical radiolucencies on tooth number 31, which indicates infection, and he may need endodontic treatment. This is his FMX, and this is his panoramic image. The distortion on the left is probably caused by the Pano machine drum brushing the patient's shoulder while it was rotating. For intraoral camera caries mode indices, this was my first time using an IO digital camera. I used the carie mode on the intraoral camera as part of my caries assessment. The rationale is the intraoral camera is available and ready for use. Also, the patient has obvious signs of cervical carious lesions, mostly on buccal surfaces. I was also curious to know if he had occlusal caries and how they would appear on the screen. A few of the occlusal and interproximal dental caries appeared to be red in color, including the facial or buccal carious lesions. For analysis, Bill is classified as an AEP of 2, localized 3 patient, which I have mentioned earlier. His deposits for plaque stain suprasub are 5145. Bone loss is generalized slight to moderate horizontal and localized moderate vertical. Case type 5. The contributing factors are the patient has dexterity issues, only uses regular toothbrush, patient does not brush and floss teeth regularly, patient has not visited a dentist for 16 years, patient takes several medications which lead to xerostomia. He has poorly contoured amalgam restorations. He drinks ketogenic beverages such as sweetened tea and sodas. He eats white bread instead of whole wheat bread. Rationale for decisions. Patient has generalized chronic severe gingivitis and generalized slight to moderate adult periodontitis. Treatment outcomes. Patient has been focusing on taking good care of his teeth after gaining some knowledge from the patient education which I have provided. With patients' drive to live a healthy life, the prognosis is positive. And agreeing to be a recall patient should lead to improvement or stabilization of his periodontal issues. This is his treatment plan that I had put together to get the best outcome possible. It has the pre-treatment plan, proposed treatments, oral hygiene aids, and so forth. For implementation of planned treatment, the implementation of planned treatments started well. The patient gave verbal and written consent to be my periodontal project patient. A treatment plan was approved by instructor and presented to and signed by the patient. Dental treatment was started on May 3rd and ended on May 31st. Patient was happy with the dental services I provided and was very satisfied. The overall treatment went well with no complications. Patient came back on May 31st for completion and evaluation of treatment. Patient was pleased with the outcome. Evaluation of treatment. The use of Eastman Interdental Bleeding Index disclosed a reduction of bleeding from 75% to 14%. This is a significant improvement. For gingival assessment, notice that the gingival tissues are generalized pink and localized pale red in color, indicating reduction of inflammation. Probing depths were mostly decreased, and there was an absence of fistula on the upper right quad, apical region between the two premolars, mostly towards number 5 apical region. There was reduced number of bleeding points. Furcation measurements are stable. Contour is firmer and resilient. There was reduced calculus deposits. The gingivitis has gone from a severe case to slight to moderate. Improved home care and better understanding of oral health. This is the 4-week evaluation or the post-therapy evaluation. In this post-therapy appointment, I evaluated the upper left quad and 4 selected teeth, the number 25 to 28. And there was such a significant difference or improvement noted from the initial visit to the time he was evaluated. And here's how patient's oral condition appears at his post-therapy evaluation. As noted, Bill has dexterity issues, but this will get resolved. My patient promised me that he will start using his new toothbrush, his power toothbrush, and this will result in a much better outcome. For self-assessment, the intraoral images of the entire dentition at his initial visit should have been obtained. That way I will be able to get the exact representation of his initial condition, and I could have obtained his EIBI for the whole mouth, and I could have made a study model for him to get, in order for me to be able to provide him a better patient education. The bottom line, it was a great learning experience for me, and thank you very much.